Welcome to Chatting Shit with Ostique, the podcast series where we chat about shit with inspirational people from all walks of life. Today, we are joined by the wonderful and inspiring Dr Phil Tozer. We hope you enjoy this conversation. Phil, welcome to Chatting Shit with Ostique.
Thanks very much. I'm excited to be here.
Thrilled to have you here. Everyone will notice we also have a guest host today. Caps, would you mind introducing yourself, please?
Hi, welcome guys. My name's Kapil Sahnan. I'm one of the consultant surgeons at St Mark's and a previous mentee of Phil Tozer, so I'm really excited to hear what he's got to say about this.
I didn't know that. That's great. Today's topic is sex with a stoma. And Phil, dare I say, you are the leading expert on this topic, so I'm very excited to hear from you. It's a topic we actually don't see covered enough, and it's one of the topics that we get the most questions about from the community. And as I mentioned before we started recording, a lot of the community have submitted their own questions, which we will absolutely touch on as many as we can towards the end of this episode. Before we get into it, Phil, I wondered if you could just briefly introduce yourself and talk a little bit about your background, and then we'll launch into the study.
Yeah, so I'm Phil Tozer. I'm a surgeon at St Mark's Hospital. I'm an IBD surgeon, and I do proctology and post-disaster work, that kind of thing. And I have long had an interest in outcomes, in quality of life work, like inflammatory bowel disease and proctology. It's not about saving a life like you do with cancer. It's about improving quality of life. And of course, every time we touch somebody, we have the opportunity to make them worse as well as better. And so understanding the impact of our efforts on patients' quality of life is really important. And CAPS's work was one of the first to really address that with a core outcome set that we might chat about later. And lots of the work of the Fistula Research Unit that I work in with colleagues at St Mark's has looked at this stuff since. And so I got into the whole question of sex because it's really one of the areas of quality of life that we just don't talk about within surgery and medicine as much as we should. And you kindly said that I'm an expert in this. The truth is I'm not, and I don't think anybody is. I think that's really the crux of the problem here. But we are starting to try to address that deficiency. And part of that is destigmatizing the conversations around sex, and part of it is about trying to educate clinicians and patients about sex and about how they should be discussing it in their consultations. So Olivia, if I may say so, this is a perfect topic for a conversation, and I'm delighted to do it.
Delighted to have you. I'd love to talk about your study, which, let me make sure I get this title right. Let's Talk About Sex, a patient-led survey on sexual function after colorectal and pelvic floor surgery. Correct?
Yeah, so this is actually one of the pieces of work I am most proud of being involved with. I should say that it was Nicola Dames who did the main work on this, and she is a patient. And she's involved with the world of healthcare, both through work with the patient liaison group in various of the organisations that we work with, the colorectal organisations and gastroenterology organisations. And she's also got a company which is interested in underwear for people with stomas, which is a really brilliant, practical way of trying to address some of these issues. And she's a fantastic individual. And she started this work and then invited one or two of us clinicians to become involved, and I was very happy to do so, really to try and help bridge the gap, because we wanted to produce a piece of work that could be published in the medical literature. And that's a very hard thing to do if you don't know the tricks and the phrases and all of that kind of thing. It's a hard thing to do even if you do know those, but it's particularly hard if you're not kind of in that world. And it was important to me to try and get the patient voice over to clinicians through that. And there was a whole team of people, of course, who worked on this, including other clinicians and patients. So yeah, it was a super, super exciting piece of work.
And what did you, I guess, set out to either discover or prove through the study? And then kind of high level, what were the key findings? We can then delve into some of those.
Yeah. So the main thing was to try to understand the impact that surgery has on sex, and also that disease has on sex. We have a much greater feel for the impact that disease has on sex because patients come in and sometimes tell us, although not as much as perhaps they might. But the impact that surgery has on sex is much less clear to us. And in addition to that, the other important aspect of this was talking about how we do or don't talk about sex in consultations. So if you come in for an operation with me, Olivia, and I'm going to do an operation which has an impact on your perineum, okay, so the tissues between the vagina and the anus, that is going to have an impact on your sex life down the line. But most of the time, when you come in and I talk to you about that operation, you will never hear those words. No, I will never say that to you. In general, they don't. And what we found in the survey was that around 80% of people who had an operation like this said that sex was never mentioned to them at all. Now, you might say that 1 in 5 is not terrible. It's pretty bad if you're the other 4 in 5, obviously. But even those 1 in 5 were probably not having the kind of in-depth, detailed, valuable conversation that we might hope that they would have, and that they would have if they were, for example, a concert pianist and you were talking about an operation on their arm. Very straightforward conversation. We get taught about that in medical school. Well, everyone's a concert pianist when it comes to sex, right? Everyone is doing it. Everyone wants to be able to do it well and enjoy it. But we don't have that conversation. And so that was one of the kind of key points of doing the survey. So Nicola rolled the survey out. She got more than 600 respondents in about a day and a half.
Not surprised.
No, you just don't get that in medical. If I send out a survey to my colleagues, I'll be scraping for 60 responses in 6 months. So it's incredible the kind of outpouring of information that she received so quickly, and she identified a few key things. And it's important to say that the patients who responded were mostly young people, women, mostly with IBD, often with stomas, and that's the group that she is often talking to. And so it's important to recognise that we weren't capturing everybody, but about half of people said that they lacked body confidence to a moderate or strong degree following surgery. A third of people modified their sexual practices to at least a moderate degree after surgery. Only 1.4% met a psychosexual nurse specialist, and that would be a fantastic addition to most services if those appeared. And as I said earlier, about 80% of people said sex was never mentioned before surgery.
So, Phil, I might ask you a quick question. So it's an intentional question, but whose role is it to talk about sex, and who classically does it, and how do you practice?
So I think the easy answer, the slightly lazy answer to that is it's everybody's role and nobody does it. And I think that is broadly true. In the survey, patients were asked exactly that question. And about 3/4 of people said stoma nurses should discuss it. And about half of people said it was surgeons that should discuss it. Now, it's important to remember the bias inherent here, because there were, the majority of people asked were women, the majority of stoma nurses are women, the majority of surgeons still, sadly, are men, although that is rapidly changing. And so there's a clear question there about whether people will find it easier talking to people of their own sex about this conversation. And that is probably supported by another piece of work that was done a while ago amongst cancer patients. And that found that older men were more likely to have a conversation about sex than any other group. And of course, they were having conversations with older men who were the surgeons. I think there is a whole big thing about it's easier to talk to somebody about sex that looks like someone you might normally talk to about sex in the pub or whatever. The truth is, of course, that you can't always control who your clinician is, and clinicians certainly can't control who their patients are. And so you've got to make it work. And that means if I'm talking to you, Olivia, or you, Caps, or a 75-year-old lady who has always been brought up in a reserved way, maybe of a different race to me and different religion, we have to make it work as best we can. That doesn't mean that you have to ram a conversation down somebody's throat when they just are not into it. But it means you have to find another way for them to have it if you can't. So if I can't have that conversation with them, I'm going to engage a stoma nurse or an IBD nurse or a biofeedback nurse or one of my female colleagues or maybe one of the nurses in clinic, some of whom are brilliant at this stuff. Get them involved, get them to do it, or get them to be there to help if that's appropriate.
Off the back of that, I think I've got kind of 2 specific questions to delve into that more. One would be, what information specifically do you think needs to be made available pre-op? And also, if a consultant is going to have that conversation, what's your advice about the best way to go about handling it?
Yeah, good. So that's a couple of hours for each question.
Yeah.
So what information to give is absolutely crucial. The question centres around consent. In general, I'm offering at least two options, because there's always the thing I want to do and nothing. There may well be 3 or 4 or 5 options that we could pursue. None of them is necessarily better than the other from a medical point of view. But even if they are, the question about which option you might choose is entirely the patient's. So we're just custodians of this information. We are giving it to the patients in order that they can make their own choice. They can only make a clear choice if they understand the impact of the operations that they're going to have. And in terms of sex, that means you need to know what kind of sex they're having in order that you can have that conversation. So, for example, some of the operations I do remove the anus. So you're sewn up underneath like Barbie or Ken. Okay? It's a really, really good operation for some people. It really transforms lives. But it will completely take away that aspect of your sex life if you are into anoreceptive intercourse. And it would be terrible for me to do that to somebody without them realizing that. And for me to not offer them an alternative if anoreceptive intercourse is actually a key part of their life. They might prefer to have some other aspects of their disease continue than to lose that part of their sex life. And that balance is for them to make, not me. So what information do we give them? We have to tell them exactly what we think the impact will be on their life from the operation that they're going to have. And that will involve when they will be able to return to work, whether they'll be able to sit comfortably, whether they'll still be able to do their favourite activities. So surgeons will often ask, what kind of stuff do you like to do? Are you a horse rider or a swimmer, or, you know, this kind of thing? What are the things you do for fun? And part of that should be about sex. What kind of sex are you into? What do you do? How will that be affected by what I do? And sometimes it's a relatively obvious answer, right? If you do an operation on someone and damage their ability to have an erection, well, that's going to be important for most aspects of sex. It's a bit different in terms of anoreceptive intercourse, or for women in terms of vaginal intercourse. You know, what are the important aspects? Some of the operations that we do will damage the nerve tissues around the vulva. So the labia, the tissues around the vagina, very sensitive tissues, very important that they are, working effectively for sex to be pleasurable and not painful. And some of the operations we do can damage that, can cause numbness or even pain in those areas. So it's hugely important to talk about that. So that's the first thing, is to understand exactly what the impact the operation will have in the context of the patient's sex lives, which means we have to ask them about sex. They have to tell us what they're doing, and then we can explain what impacts the operation will have in the context of that conversation.
Most of the female guests I've had on this podcast have told me that sex is incredibly painful. Every single one of those has a stoma, just to be clear. And most of those had IBD before that. And none of them were told that that would happen beforehand as well. So I do think it's really important to bring this up. You mentioned that there can be erectile function issues as a result of surgery as well. What are the impacts and implications? I'm sure there's plethora and it's quite difficult, but what are the key things that you should know could be impacted by stoma surgery in terms of sex?
Yeah, so it depends a little bit on the nature of the stoma surgery that you're having. If you have, this is going to sound very trite, if you have just a stoma, what I mean by that is if the only part of the operation we do is where the stoma is, so we make a hole in the abdominal wall, we hoik up the bowel, that's it, then there shouldn't be any real impact from the surgery on the perineum, on the anus, the vagina, the penis, and so on. And so you shouldn't really get any impact in that area, negative impact from the stoma. You certainly can get pain around the abdominal wall. And of course, we make a hole, right? What a stoma is a controlled hernia, right? We make a hole and then we bring bowel up through that and we open it up. And so that can cause pain around the sites. Usually, I would say that discomfort after surgery tends to ebb away and patients don't have pain afterwards, but they can have prolapse and other problems associated with stomas, including hernias around the stoma. I think probably the biggest impact that people talk to me about is body image. And of course, that's hugely important. There is great work from things like the Get Your Belly Out campaign and very many stoma warriors online who will show you fantastic pictures of their bodies with their stomas in situ. And it's, deeply inspiring and fantastic. But I do also feel for people who are about to embark on that journey, who feel that that is just another example of an unattainable body image demonstrated to them online. And it's not always ideal for people to see, I think. Anyway, body image is a huge part of all of this for them. And that's where things like particular types of clothing, underwear, and so on can be really helpful, which will cover the stoma, but leave other aspects of your body uncovered in a sexy way. So that, I think, can be helpful in that regard. And there's lots of discussion amongst ostomates about whether they wear a stoma belt during sex, for example, because it kind of covers it up, keeps everything away, prevents the bag from filling too much, and so on, and allows them to get on with sex and what sexual positions they'll undertake and so on. And of course, these are conversations that our stoma nurses should be having with them. But I don't think they do very much. I certainly think that that's uncomfortable for them. Anyway, body image and to a lesser extent, I suspect, pain and discomfort are probably the two main things that people talk about with stoma surgery itself. But then sometimes you're making a stoma because you're taking out the rectum, for example. You might do that for a cancer operation. You might take out the rectum and the anus in an inflammatory bowel disease operation or a cancer operation. And in that case, you're dissecting down in the pelvis. And it's not the stoma at that point that causes trouble, but as soon as you dissect in the pelvis, you can damage the nerves that supply erection and ejaculation, and also the nerves that supply sexual function for men and women. So in terms of sensation and, clitoral erection and so on, blood flow down into the vulva. And you can also, drifting off the topic of sex directly, pinch off with scar tissue the fallopian tubes. So eggs find it more difficult to get down from the ovaries into the uterus. And so every period, every ovulation doesn't necessarily result in an egg appearing in the womb, and so you can't get pregnant that month. And that's a reduction in fecundity. It's a slightly different phrase to fertility, which everyone is used to. So you can still get pregnant, you just might not this month, and so it reduces your ability to get pregnant. And so all of those are impacts from the pelvic surgery rather than from the stoma itself.
And Phil, if I just in case somebody's asking, what would you quote, and I appreciate it's completely nuanced and bespoke for people, when you speak to, let's say, a young lady who's about to have pouch surgery, what's the number that you kind of speak to them about?
Well, let me throw that question back to you, Caps. What do you say to them about fertility?
So I think it's really difficult because obviously, at Smarts, we're now doing different ways of operating. We're using the robot, which is supposed to have a better way of looking at nerves and preventing things. So that's an answer that we're answering as part of a PhD. So that's why I thought I'd ask you. So we'll tell you that answer exactly with new novel data in about a year and a half's time.
I think that's exactly right. The truth is we don't really know with the robot yet, and to a greater extent we do with laparoscopic surgery. Certainly, it seems better than with open surgery, but it shouldn't be the case that a woman who is young and would otherwise get pregnant, the reduction in her ability to get pregnant is present, but it shouldn't be huge, and in general that is balanced by disease. So if they don't go ahead and have that pelvic surgery, then the ongoing disease will also affect their ability to conceive. And so there's usually quite a nice balance there. And it's usually the right thing to opt for surgery. But there are sometimes operations that preserve the pelvis. And actually that might be one argument for having a stoma, keeping it.
Yeah.
If you're doing an operation for ulcerative colitis, say, you might leave the rectum in situ, give the patient a stoma, let them get on with that first 5 or 10 years of their young adult life where they're building their career and also building their family, and then go on and do the pelvic surgery down the line when it's a little bit less important to them.
Yeah.
In terms of men, we quote an impact on erectile dysfunction and ejaculatory dysfunction of around about 3 to 5% with first-time pelvic surgery, and that goes up to about 5 to 10% with redo pelvic surgery, which we do if we have to go into the pelvis a second time to remove a failing pouch or for whatever reason. So it is a fairly substantial impact, and it's a much better known number in men because it's a much more binary issue, much easier to describe, and also perhaps because it's much easier to talk about amongst men who were predominantly the people having this conversation 20 years ago when all of these figures were derived.
I might ask you another, just a very interesting question. How do you find having these conversations with couples? Is that a beneficial thing? Do you sometimes invite a partner into the room to have that conversation? Do you find it hinders, or again, is it bespoke and nuanced?
It's fascinating, isn't it? So let me broaden that question to who should be in the room. It's fairly obvious that the patient's parents probably shouldn't be, and usually you can encourage. You can ask the parents to leave during the examination, even if there's a curtained off area in the room, as we have, and they'll go out the room, and then you can start that conversation. That's a great moment as well, because a nurse has just walked in the room to help you with the examination. So you've got a chaperone. The patient can feel less isolated because they've got usually a woman sitting with them, and their parents are at the room. And so you might have a long examination, which is only a normal examination, and then 10 minutes of chat afterwards with the parents outside. Sometimes people want their parents there for these conversations, but that is less common in my experience. The whole partner thing is really interesting because I think a lot of people want their partner to be there, and they will have that conversation maybe for the first time actually with their partner, with you there. Sometimes they don't. Sometimes they want them out of the room because they're too embarrassed about it. And that is a really interesting thing with regards to sex, and perhaps returning to sex after surgery. Sometimes making that journey with your partner, for some people that is exactly the right thing to do, and it's empowering and it's great for their relationship. For other people, making that journey with their partner means that if it goes badly, if they have a lot of pain during intercourse for the first time after returning to it after a 3-year abstinence because of disease and surgery and so on, then that's another 3 years where they're never going to have sex because they're so miserable. That event was so traumatic for both of them. And so psychosexual therapists have this thing that they call solo graduated exposure, which is something that this is the bit, I'm fairly relaxed about these conversations. This is the bit that even makes me blush when I'm talking about it with patients, particularly with young female patients. So it's the idea that first sexual experience that you have when you return maybe is best done on your own. So one of the biofeedback nurses I used to work with, a lovely lady called Trish, she's retired now. She was 60 years old, looked me in the eye and said, "Phil, you've got to tell them to go to Ann Summers, pick something off the sex toy table that they recognise, that looks a bit like their partner, and get them to take it home and have their first return to sex with that toy, so that they are not having that experience, that potentially very negative experience with their husband. And they can explore, do the things that they enjoyed before, are they still pleasurable? Do some of those things now hurt? And they want to move away from those. And they can then have that conversation with their partner when they they will know, and they'll be able to do that in their next conversation. It's a straightforward concept. Of course, when you think about it, it's the kind of thing that people do not ever talk about.
I wondered if we could dive into, and I don't know how much is available in terms of data for this, but a lot of people say that the positions that they used to really enjoy following their surgery, they can no longer do. And I know in your study, I think you found that more of a third of the respondents had to modify their positions in some way, shape or form. Do you know if there are any kind of blanket positions that you should just be avoided full stop if you've had surgery in that area, or potentially that might be a way forward where you can have sex without pain?
Yeah, so it depends on where the pain is arising from, and so all I can tell you is what patients have told me, rather than rather than there being evidence data from the literature. There just isn't any, to my knowledge. So if you've had perineal surgery as part of your stoma creation, then that obviously has a very direct impact in terms of pain. If I've made a cut into the labia on the left-hand side, that is going to be more painful, at least until that has healed. Yeah. And so any kind of penetrative intercourse then will be painful immediately as what we call superficial dyspareunia, means pain during intercourse on the surface. Pelvic surgery is a bit more difficult, and then you can get deeper dyspareunia. And so if you think about the pelvis, the female pelvis, the vagina sits right in front of the rectum and the anus. Now, if we remove those, the back wall of the vagina tends to flop backwards a little bit.
Right.
That can have an impact on penetration, how comfortable it is, sometimes even how painful it is. And there will be scarring behind there, even if there isn't a problem like a cavity or a collection. Even if it's healed beautifully, there'll be scarring behind there. And so women report that sex changes, penetrative sex changes after that kind of operation, but may in particular may get worse, may become painful. If that's the case, then taking pressure from the penis off the back wall of the vagina is obviously a useful thing to do. And so if you change sexual position from missionary, for example, into doggy style, then you're going to have a much more straightforward time from that point of view, because the pressure from the penis then is more forwards onto the front wall of the vagina, away from the back. That might be the case if you've had a posterior vaginectomy. That means if you've had, for example, a cancer removed at the back and the back wall of the vagina has been repaired, it might be a bit tighter than it used to be because there's been some tissue loss. And there'll be a scar at the back there. Again, it may be better to try and shift pressure away from the back wall of the vagina. And the same is true with fistulas, for example. In terms of anal intercourse, any surgery we do to the anus can have the same kind of impact. So if you've got a seton in, if we've put staples into the anus, obviously absolutely crucial for patients to know if they've got staples in the anus, which we often use to make joins in cancer surgery between the rectum and the anus. Those staples are a real problem for their partner, whose penis can be lacerated by those staples. Big deal, obviously. And in terms of the stoma itself, that's a little bit more nuanced, I think, and it will depend. Some people find that pressure down on their abdominal wall is actually comforting. It relieves discomfort. And so you sometimes see people pressing on their stoma if they're going to cough or whatever. And in that case, it may be better to be face down on the bed for the person with the stoma. Sometimes it's better to have no pressure on the abdomen. So then, ostomate on top.
Yeah.
Or again, doggy style might be more comfortable from that point of view. So I guess the answer is experimentation is the right thing. And I think because there's no clear advice from healthcare professionals, that's opened a gap for really good advice, I think, from other ostomates. And these are the kinds of things that come up on chat threads, and probably they are the right people to answer that question rather than us. But those are the broad ideas that we would think about.
Just to go back specifically on that one point, how soon after a joint surgery where you had staples in the rectum would you suggest that patients start experimenting as you described? How long do the staples last?
So say it again.
How long do the staples last, Phil?
Yeah, well, the staples are there forever, and the impact of those staples can therefore last forever in terms of anoreceptive intercourse. And I think if a person where anoreceptive intercourse is a key part of their sexual repertoire is going to have an operation with a joint in the rectum, then that conversation needs to be had. There are other ways to make those joins, although they are sometimes absolutely not suitable. Sometimes stapling is the only way to do it. The patient needs to be able to make that choice, because that will probably be the case that they won't be able to have anal intercourse safely in the long term, although people do. And sometimes it's okay. You definitely wouldn't want any kind of interference with the anastomosis. That's not just the joint that we make. That's not just sex. That's putting suppositories, anything other than a gentle examination by a surgeon, a good colorectal surgeon who knows what they're doing. You would not want that to be done for weeks and weeks after surgery. We would certainly say 6 weeks. I'd probably say for things like anal intercourse, I'd push it out to 3 months. There are no data on this, of course. No one knows the answer, but that's the kind of advice that I would give. And essentially, the longer the better, certainly out to around 3 months. I suppose the issue of a join in colorectal surgery is really, really important. And that is it's almost an entirely separate set of questions that you really have to have with your colorectal surgeon, who will tell you what they want you to do with your anus and rectum in the period after surgery, and they'll have their own very specific advice.
If the advice is, or if you have Barbie butt surgery, for lack of I don't know the actual term, I just know that, or it's just not possible for you to practice anal penetration ever again, what other options are there? So I've heard that people have experimented with having sex with the stoma itself. I have no idea how common that is or how safe that is, but are there any other options that are made available to people?
So sex with a stoma is quite a difficult topic. And the advice that everyone will get from healthcare professionals, stoma companies and so on is that it is a bad idea. Now, of course, that doesn't mean that people won't do it. But, people talk about the vagina and the anus as being designed for intercourse. Mostly the vagina is the people who talk about orifices being designed for intercourse are mostly talking about the vagina. The truth is that nothing is designed for intercourse, but over time we've evolved for these things to work, and they do. And it is safe to have vaginal intercourse. It's safe to have anal intercourse. We know this. Stomas are not an evolutionary process in that sense. They are created by us. They are genuinely designed, and they are genuinely not designed for sex. How safe is it to have sex with a stoma is not known, to my knowledge, and we would all therefore advise against. But it's a real thing. It's the Philly sidecar is one name for it. Some people talk about docking, although that has other meanings, I believe, elsewhere. So it is a thing that people do. How can you make it safe or safer without advocating that it's a good thing to do? We can certainly say that no one should do it early. So again, in those first 3 months or so after surgery, it is really trying to form strong attachments to the surrounding tissues, right? We've made that the two things are unconnected except with the sutures at the skin. And, if you pushed really hard or cut out the stitches, you could push the stoma back inside. That is the case right up until it has firmly scarred and healed in position. And that, I would suggest, will be at least 3 months. So I would not advocate anyone do any kind of penetration of a stoma up until then. The next problem, of course, is what happens to the stoma as it goes through the abdominal wall. Sometimes it's a nice straight tube straight through. Sometimes it isn't. Sometimes it kinks a bit. Some of the bowel has come up into the abdominal wall. And so it's not that easy. You sometimes will see a stoma nurse or a surgeon put their finger into a stoma, and they'll scrunch up their eyes and suck their teeth as they try and find the way through the abdominal wall, because it's not a straight line. There's a kink in there, or more than one kink. And sometimes that happens right underneath the abdominal wall. And so the bowel suddenly changes direction as you get through the sheath and outside the abdominal wall. And then you've got a fixed bit of tissue through the abdominal wall and an unfixed bit of tissue that's flopping around inside the abdomen. And anywhere you get something mobile and something fixed, there's an opportunity to tear.
Okay.
I don't know. I'm not aware of any reports of bowel tearing through intercourse with a stoma, but I've absolutely no doubt that it will have happened. And that is a real concern. So if someone was going to do this inadvisable activity, then they should definitely build up to it slowly, carefully, after a long period of allowing the thing to heal in place, lots of lube, and be very conscious about stopping if they came up against substantial resistance. Remember that you can tear your bowel without it hurting. It doesn't hurt for bowel to be cut. Bowel doesn't have sensors that say, I'm being torn, I'm being cut, because it doesn't need them. It's not a thing for bowel to be cut in life. It hurts if it erodes, if there's an ulcer on the inside of it. It hurts when it perforates and gives way, but not because of the hole in the bowel, because of the stuff that leaks out and gives you peritonitis. So it is not good enough to say, as long as it doesn't hurt, it must be safe in terms of bowel. So it's a very difficult area to talk about, and again, absolutely not something that I or any healthcare professional will advocate. But those are perhaps some ways to make it a slightly safer thing to do.
And Phil, I might just ask you to expand on some of the lessons we know from people who insert items into their rectum about getting lodged up and things like that. And the advice there would be to come into A&E and see a doctor, wouldn't it be?
Yeah, absolutely. So any kind of insertion, is problematic if you lose grip of the thing that you're inserting, and that's what we see. And this is a well-known trope, of course, from popular media. On Scrubs and 100 other shows, we talk about the stuff in the ass box and the things that have been taken out of people. It's not a joke. It's a big deal. It's absolutely miserable for the person it's happening to, whether it's in the rectum or the stoma, partly because it can be painful, and mostly, I suspect, because it's incredibly embarrassing from their point of view. But do come in and let us take it out, because it can cause damage to the tissues. It can cause erosion, particularly if there are batteries there. If the battery acid leaks out, that can cause damage, although they're usually fairly well sealed inside these things. But whatever you do, if you lose a condom, a sex toy, anything else inside you, then do seek help, because we can try to remove them. And we can usually do that without having to do an operation where we open the patient's belly, for example, or open the bowel. We can usually fish it out the same way it got in, sometimes under anaesthetic.
Thank you for asking that, and thank you for answering that. And that's a really, really important piece of advice. Caps, do you have any more questions before I move on to questions that have come from the community?
Yeah, well, I mean, as I said, Phil's been a big mentor of mine, and every time we have these opportunities, I learn a little bit more. I don't, and I will change my practice now, specifically ask about joining. I classically join with a stapler if we have to do such a join, but that's something I will change. I suppose it's kind of to the audience that we're speaking to now, the ostomates and the patients who are watching this. What questions do you think they should come in for their surgeon or their stoma nurse? What's the opposite? Because you are brilliant at it, and because of your teachings, people like me have adopted your practice, and others along at St Mark's and across all country. But how should we empower our patients to have these conversations with their healthcare professionals?
Well, again, that's kind of you, Caps, but the truth is I don't think I am brilliant at it, and I suspect at the moment that almost nobody is. I think psychosexual counsellors and nurses are probably genuinely good at it, and the rest of us are just trying to muddle through with various degrees of enthusiasm, and that's okay. I think that's all right. The key is to start the conversation. And so you asked earlier, Liv, as well about how surgeons should have that conversation. So let me answer both of those questions together. How should it go? So the key is starting it. I think as long as that conversation opens, you will get somewhere, because most clinicians are up for it. They're up for the conversation. They're just often not sure how to start it. And if a clinician finds that a conversation has begun that they're not comfortable having, or not comfortable having with that person at that moment or whatever, then they can refer on to someone else, bring in another member of the team who can have that conversation on their behalf. That's an entirely honourable way to manage this kind of situation, in my view. So whether you're the clinician or the patient, I think it is best to start with a big, open, honest question. So for the clinician, the surgeon, that might be, tell me about sex. And that question almost never fails to elicit a lengthy response, because in general, patients have never been asked it before, or have been asked it only in very oblique ways. So a big open question that allows them to talk about the impact of their disease on sex, and then to go on to talk about the impact that surgery might have on sex. From a patient's point of view, they might say, I'd like to talk about sex, if they want that big open start and they want to discuss all aspects. Or they might say, what impact will this operation have on me, for example, to do with sex? And then they can learn about all of the different things, not just the sex things, that they should be being told in terms of good, informed consenting. And if that isn't enough, they can start to get more specific. I have anoreceptive intercourse. It's an important part of my personal life. What impact will this operation have on that? you talked about making a cut on my labia for this operation to repair my fistula. What impact will that have on my sex life afterwards? If you fail to repair my fistula, will I be able to return to sex? If you succeed in repairing my fistula, will I return to sex? And will sex be good? Will it be different? Will I need different sexual positions as a result? So those kinds of more specific questions can then follow, and those can also come the other way from the clinician. So once you get started, have some tissues at the ready, because I can tell you this is always an emotive part of the conversation. People almost always cry because it's such a big deal and they've never been able to talk about it before. And they always thank me for it afterwards. I've never had one of these conversations where people didn't say, thanks for saying that. We've never talked about that before. So it is absolutely worth doing and will be rewarding for everyone involved. You just have to start it. And I think the other point about that is to ask how clinicians should bring it up. Should we be making a big deal out of it and saying, okay, now this is going to be uncomfortable for everybody and I'm sorry, but it's important that I ask you about sex, and do that big kind of headlining thing. That's not my view. I think we should ask about sex in the same way. What's the impact of your disease on your work life, on commuting, on your social life, on sex and on sports? Tell me about those things and how those are affected by your disease. So it's just one of the things that we talk about so that it feels like it can be talked about in that way. But the truth is, I think both of those are correct for different people. For some people, it has to be a big deal with lots of caveating and signposting so that it doesn't come as a shock to them. And for other people, they want it to be a relaxed, normal part of the conversation. And you just have to try and work that out from the patient and your interaction with them up until that point, which is, of course, not easy. And let me apologise right now to any patient in the past or the future who I've upset with this conversation. It has never been my intention. And we will get this wrong. Clinicians will absolutely get this wrong from time to time. But I would say to you that if they are trying to have this conversation, then they are trying to be a good person. And if they may mess it up and they do it badly, forgive them, because they are trying to do the right thing. And it is not easy.
Thank you. I am going to ask you, I've got 7 questions here from the community. Of some of them I've bucketed together because we got quite a lot of the same ones. Some of them we've touched upon loosely, but I'm going to ask them anyway so I can give these people a kind of direct answer. So the first one is, how can removal of the rectum impact reproductive organs?
Yeah, so this is the fecundity question that we talked about a bit earlier on. And so removal of the rectum doesn't involve, per se, removal of any of the sexual organs. But the base of the penis, seminal vesicles, prostate, and nerves that supply erection ejaculation in men, and vagina, uterus, and womb and ovaries are right there. And we have to move them out of the way and try and protect them. And sometimes you can't protect them. They're involved and have to be removed and so on. So there is always a risk of injury to any of those structures, and that can have an impact on sex, but also on fertility or fecundity. The risks of those injuries is actually pretty low in the context of pelvic surgery. And you may be reassured to know that surgeons take very great care over these things. We consider it a bad outcome from our point of view, not just yours, if we damage your pelvic nerves and you don't have erections in the future, or if we damage the uterus or the ovary and they have to be removed during the operation, or if we damage the vagina during the operation and you end up with a connection, a fistula between the vagina and rectum. Those would all be considered bad outcomes, not because we feel sorry for you, but because we feel that we don't want that to happen when we're working, right? It's a thing that we hate to have done to people. And so we take great care to avoid them. And the risks of all of those things are low. And that 3 to 5% erectile dysfunction risk is probably about right for many of the types of sexual dysfunction impacts that you might get from nerve injury, but it's much lower than that for injury to uterus, ovary, vagina, and so on. Those are, in general, much safer because they're so visible and we can move them out of the way more easily. Dissection between the vagina and the rectum is very hard sometimes. And The prostate and vagina are also prostate and rectum are also sometimes very close to one another, and it can be difficult to get between them too. So those organs definitely are at risk, but they tend to be damaged in a less fundamental way. And so if I'm doing one of those operations and I make a little hole in the vagina, I'll repair it, and the patient will probably never know about it, except that I'll tell them. They'll probably never know it in the longer term. And so those things are less of a concern. So the pelvis is a place that carries real risk for us to operate in, and that's why those operations take a long time, and we spend a lot of time learning to do them very carefully.
You mentioned fistula. That's actually our next question, which is, can you have sex with a fistula in the vagina?
Yeah, so the answer to that question is absolutely yes. Okay. There is no evidence that I have seen, and no evidence anecdotally from my own patients, that having sex with a fistula in place, a rectovaginal fistula is what we're talking about, causing damage to that fistula. Now, if you had a very big fistula hole, and sometimes people do, sometimes have a hole 2 centimeters across, then you can imagine that would be pretty difficult from the point of view of penetration. It will probably only be, an inch, maybe less, inside the vagina, and so there is a risk there that you would bang into the fistula. Now, it's usually pretty strong scar tissue, and so it's not likely that you would cause real damage to the fistula or make it larger, but it would be difficult. It might be painful for one or both of you in that situation. That's a good example of a time when you might switch sexual positions to take the pressure of the penis away from the back wall of the vagina and towards the front. The times when there might be a risk are if you've got a seton in place, usually unnecessary in a vaginal fistula. That's a piece of surgical thread used to drain a fistula but not cure it. Usually they are not necessary in the vagina, but occasionally they are. And having sex with a seton in place, that might create a shearing force on the fistula, which might make it larger. A brand new fistula, having intercourse then, it won't be scarred and strong and tough. It will at that point be friable, fragile tissue, and then it could be made larger through intercourse. But you would have just developed new symptoms. You'd have pain. You'd have just noticed stuff coming through the vagina like wind or stool, which shouldn't. And so it should be relatively obvious that there's a fistula there. And after a repair, that's the other time when I would advocate against sex. Usually, I say at least 6 months. In fact, what I usually say is wait till you get out of hospital, and then nobody laughs. And then I say wait at least 6 weeks, and then probably even out to 3 months. And at that point, it's probably a bit safer. In general, though, it is safe to have sex with a mature rectovaginal fistula in place.
So, Phil,
yes.
I might just pick you up on one of those things. Like, I'm sure lots of people will watch this and ask a question. So you receive referrals from around the country for people with rectovaginal fistulas. So you are a super expert at it. But there'll be lots of people watching this saying, I have a seton in my rectovaginal fistula. Could you just expand on that kind of concept you talked about?
Yeah, so there are many different ways to divide up different types of fistula, including fistulas into the vagina. But let me divide them for the purpose of this conversation into two. Those which are a buttonhole, literally like a buttonhole in a shirt, just a gap between the rectum and the vagina, usually through the rectovaginal septum, although sometimes through the anal canal. And there are those which are long tunnels, like anal fistulae usually are, that go through the sphincter complex, usually perhaps in a tortuous pattern, but they are longer, and they might be 1 centimetre or 2 centimetres long, even, or longer. The long fistulas have a real risk of developing an abscess within them if they are not drained with a seton. The skin can close over temporarily, the vaginal opening can close over temporarily, and then pus builds up behind and they can burst out again. In order to control and reduce the symptoms from those fistulas in terms of what's coming out of them, like discharge, a seton can be useful. And I would certainly consider placing one to start with, at least in that situation. The buttonhole fistulas do not carry a risk of abscess, not substantially, and certainly not after the initial period. of drainage, which might last for 3 or 6 months, say. After that, they are not, in our view, necessary almost always. And there's no blanket rule here. This is a decision that needs to be made between you and your surgeon to discuss the risks. But in general, if I see a aceton through a buttonhole fistula in the rectovaginal septum, I will remove it in clinic because it is almost always unnecessary, and it contributes substantially to the impact on patients' quality of life, their discomfort, and so on. And of course, it has an impact on their ability to have sex. So it might be that the first time I see a patient with a rectovaginal fistula, having had surgery and been assessed elsewhere, they come down and see me, or Carolyn Vasey is my colleague who does this work at St Mark's as well. And one of the first things we will do is take out the aceton and tell them that they can have sex. And you just immediately, in those two actions, improve people's quality of life straight away. So, it's important that people recognise that is the case.
Thanks.
I'm conscious of time here, so I'm just going to pick two more of the questions, I think. We had a lot of questions around mental health, and I don't know if you're comfortable answering this, but I guess kind of a twofold question here. One, do you think enough focus is given to mental health support for stoma patients? And two, do you have any advice for people on how to work past in their mind how different their anatomy feels?
Yeah. Okay. So the answer to the first question is absolutely not. There is absolutely not enough support for people from a mental health point of view with regard to their stomas. I suspect that is mirrored throughout the mental health service within the UK, but we see it up close and personal with regards to stomas, inflammatory bowel disease, cancer, sex after these diseases, and so on. And there just isn't enough. St Mark's, we're very lucky. We have a psychological medicine unit with a psychiatrist and a bunch of psychologists specifically engaged in dealing with helping patients who have bowel disease and the impact on their psychological well-being as a result. But we don't have enough access to that. No one does. And we tell people if they can't get access through our service that they should go to their GP and try and access services locally. And of course, that's those services, brilliant though they are massively oversubscribed. And so the answer is absolutely no, there is not enough access to these things. It should be drastically reduced in the same way that most of the resources for the health service should be, in my view. In terms of advice on getting past these issues, that's a very difficult question as well. And really it should be someone with mental health training who answers it. I suppose it is worthwhile, the bit of this that we do as surgeons and gastroenterologists is to say a few key things. The first is that people who are about to have a stoma are usually much more anxious about them than the people who have got stomas. In general, the people who have them, they absolutely have their problems, and someone with a stoma will be able to enumerate them for you very quickly on a long list. So I'm not saying that there aren't any issues, but going from a position of uncertainty and fear to one of knowledge seems to make a huge difference to most patients. And for that reason, we encourage prospective stoma patients, if they can, and there's time and so on, for them to talk to an existing stoma patient who's addressed these issues right at the coalface and can demystify stoma for them in a big way. And the other great resource from this point of view is stoma nurses. And so the stoma nurses, they'll teach you how the bags will work and how you get your supply, and they'll show you what a stoma looks like. But they should also be talking to you about diet and sex and mental health. And those are key elements of a stoma nurse's work, in my view. And they should help and encourage people in comfort with the idea of a stoma and when it comes with the stoma itself, and also identify those people who need additional support, mental health support, for example, and encourage them and facilitate them seeing someone that they need to.
I am going to thank you so much, both of you. And I'm going to put this in the caption for the podcast, but I think this is the most important podcast we have done today, and this I think is our 24th. So thank you so much for coming on and being so happy to answer any of the really specific questions, even when I'm sure it might feel a little bit uncomfortable for you at times. And thank you also for doing the work that you do. I know it's going to mean a lot to the whole community. So thank you both so much. Have you seen the new Ostique skins yet? Ostique skins are revolutionary ostomy pouch covers that were created to make the wearer feel confident, sexy and powerful in all of life's moments. From moments of intimacy to lounging by the pool, conquering a workout or simply heading out to lunch, skins have you covered. Even better, they're compatible with all major colostomy and ileostomy bags. Ostique skins are available in a range of colours and skin tones, and they're made from a revolutionary material that's completely waterproof, high quality, soft and comfortable. Skins are easy to use, even with reduced dexterity, and they work with both closed and drainable bags. Plus, skins are also environmentally friendly and vegan. There are 4 bundles available to buy now, and you can also purchase individual skins. Head to ostique.co.uk to find out more.